Much. There are several questions for the whole faculty. There is a question again raised about 3 to 5 times about using of merinone and dobutamine, which results in using of vasopressin and norepinephrine in Dr. Anna's case, and about the role of the indicators for using of vasopressors, particularly for vasopressin. And one colleague is concerned about the risk for splanchnic ischemia with using of vasopressin. What do you think, Dr. Anna?
Okay, we use these agents, titrating the dosage for each patient, and we wean off as soon as the patient is stable and normovolemic.
There is another interesting question for the whole faculty, and Fanny, if you want to comment on this. Interesting point is the reporting to mechanical circulatory support in case of right ventricular impairment consequent to refractory pulmonary hypertension. As the lecture mentioned, the ECMO and RVAD. My question, what is the indication for ECMO or RVAD on the management of such patient with pulmonary hypertension and right ventricular failure? Please describe the weaning procedures leading to explanation of mechanical circulatory support. If you have checklist or if we have indicators for considering mechanical circulatory support in this patient during weaning.
In case of left ventricular assist device, we try to help the right ventricle to follow the very good left ventricle, which is the LVAD. So we try to help the right ventricle with inotropes, vasopressors, and combination of 2 inhalers in order to take into advantages their combined action, because they act through different pathways. If we cannot support the right ventricle enough, we turn into the implantation of right ventricular support, mechanical support. This is a bit complicated because there is a high percentage of adverse outcome. So in order to avoid to implant right ventricular support, in this we use all this therapeutic management. And we have in our department we have published work about the patients with this candidate for left ventricular assist device implantation, and we treat them with inotropes, adrenaline and inotrex, in conjugation with two inhalers, NO and tiloprost, and our patient has a favorable positive outcome without needing LVAD implantation.
Okay, there is another question related to the same point, Fanny, if you want to address it. Do you have any experience in using of right impella or right ventricular mechanical support in perioperative period?
There is experience in our department with LVAD or ECMO. We are most experienced in ECMO placement in order to give time to the right ventricle to improve its function, and that we prefer. We prefer ECMO.
Okay, thanks. Thank you, Fanny. There is a question for Dr. Fitikos. Are you using pulmonary vasodilators for all types of pulmonary hypertension? It might worsen pulmonary edema and type 2 pulmonary hypertension, according to this colleague.
Yes, there is this danger exists, especially with nitric oxide and isoprostanol, and we should be very careful, especially in patients with severe left ventricular dysfunction, since the increased pulmonary blood flow and increased left ventricular preload will lead to pulmonary edema. So it is necessary to support left ventricular function in order to avoid pulmonary edema. We should be very careful or avoid the use of pulmonary vasodilators such as nitric oxide or isoprostanol in these patients.
Thank you. Dr. Zokas, there is a question for you.
Yes.
Have you ever considered using volatile agents, volatile anesthetics instead of intravenous agents in the ICU in patients with pulmonary hypertension who were sedated and they're ventilated, mechanically ventilated? Do you think this could help for any reason?
Yes, thank you for the very interesting question. To be honest with you, here we never use this practice, but in some studies, they have tried using volatile agents. I think only sevoflurane in patients undergoing cardiac surgery, and they found that they have shortened extubation times. They have less delirium cases, and if I remember well, in a study where they measured the troponin levels 6 and 12 hours later, they found significantly reduced levels using volatile agents. So yes, I would be very happy to invest this scenario, to put in my practice in the ICU the volatile agents, and especially the sevoflurane, for who we have some data from the literature. Very, very interesting question. Thank you.
Thanks so much. We have still some questions, but we don't have time. We are running behind time. So the unaddressed questions that will be answered by speakers and be posted on the EACTA website. You will receive a notification on social media about this later on. And now, without further ado, I leave the wrapping up for Dr. Antoniou.
I will try to have a soon presentation because we have no time, and I stay in more interesting issues. Pulmonary hypertension is a complex and progressive disease, and is accompanied by elevated perioperative morbidity and mortality. And the main reason for this morbidity is right ventricular dysfunction. So our main consideration is to improve right ventricular function. I would like to keep in mind that there are downregulated in the pressure overload, downregulated of beta-1 and alpha-1 adrenergic and dopamine-1 receptors as well, with cause to diminish the inotropic response. Furthermore, the vagal nerve stimulation preserves right ventricular function, but this still needs further investigation. As far as management of patients with pulmonary hypertension, we follow 4 steps. First, to treat factors that may precipitate in increased pulmonary hypertension. And I should stand only in arrhythmias. In case of arrhythmias, the preferred agent is amiodarone, because D blockers are poorly tolerated. And if sinus rhythm cannot be restored, the Zitalis should be considered with caution. As the previous speaker presented, we ought to optimize right ventricular preload. I would like to say something about inhalation anesthetics. Inhalational anesthetics blocks ATP-dependent potassium channels whose activation induces vascular relaxation except sevoflurane. So, in case that we prefer inhalation anesthesia, we ought to use only sevoflurane. And the orientation of pharmacological treatment is twofold. First, to maintain blood pressure and cardiac output, and this we can do that by giving vasopressor in combination with inotropes. We use this combination because the vasopressor used with caution, of course, can maintain the blood pressure and coronary artery perfusion. And we combine with inotropes in order to preserve cardiac output through improvement of right ventricular contractility, And finally, last but not least, we ought to reduce right ventricular afterload in order to reduce the work of the right ventricle, and the preferred agent are agents with pulmonary selectivity. And in our arsenal, we have pulmonary vasodilators like milrinone, NO, epoprostenol, iloprost, and sildenafil. And by giving this agent by inhalation route, we have a reduction of pulmonary vascular resistance without significant influence in blood pressure and cardiac output. These current agents follow three pharmacological pathways. So we can combine the use of inhaler vasodilators in order to exploit the additional effect because they act for different pathways. In this study, we have 19 patients that scheduled to undergo L-band implantation. These patients have severe pulmonary hypertension and moderate right ventricular function. Furthermore, in inotropes pharmacological, except the administration of inotropes, the vitamin or adrenaline, we use the combination treatment with inhaled NO and inhaled iloprost, and we observe sufficient decrease of pulmonary vascular resistance and mean pulmonary artery pressure on the basis of an additive effect that improve right ventricular function and avoided the need of right ventricular assist devices. And I would like to underline that the pulmonary hypertension management is only based on expert opinion. No, we have no guidelines for intraoperative management. So my proposal is to develop an algorithm concerning perioperative anesthetic management. Thank you for your attention.
Thanks so much, Dr. Antoniou, for this interesting wrap up. And before leaving, I want to express my appreciation and thanks to Onassis Cardiac Surgery Center to support this second episode of EACTAIC Fellowship Seminars. Special thanks to all speakers for their dedicated time and commitment to make this event. Special thanks to Dr. Theofani Antoniou, the Director of the Department of Anesthesiology at Onassis Cardiac Surgery Center, for moderating of this seminar. And I, on behalf of the President of EACTAIC, Professor Patrick Waters, and my colleagues and board of directors, I'm delighted to thank all of you to coming tonight and your support, interest to attend EACTA seminars and webinars. I want to announce about the upcoming events. The next one, it will be on May 9 from the Vascular Subspecialty Committee about monitoring during vascular surgery. It is a webinar. And then we have echo course between 11 to 14 of June. And in July 4, it will be the 3rd episode of fellowship seminars from Bad Oeynhausen from Germany. Before I leave, I have to thank the great team working behind the scene from AIM Group for supporting and organizing this webinar. Thank you so much and have a lovely evening. Thank you. Bye-bye.